Hello, my name is Elaine Bowes, and I want to speak to you in regard to preparing the patient for PD catheter insertion and pre and post implant care. Firstly, it's important to understand that the patient's catheter or TENCOF is their lifeline, and so managing to get an infection-free patent catheter inserted is the first point of care. It's important to ensure that PD nurses are involved at every point of this process because they are vital in ensuring that pre and post operative care is delivered well. Getting involved too late can result in PD catheter complications, and community support, especially pre catheter insertion assessments in the patient's home, can be vital at this point. Fostering a relationship with the patient is extremely important, and this can be done through education, assessment, informed decision making, and support. And you may want to consider pre implant training for the most vulnerable patients so that they have confidence in their care. A dedicated access team is extremely important, as laid out in the ISPD Guidelines 2019. Planned access, where possible, including education. It is very important that the abdominal assessment is methodical. Bacterial screening and antimicrobial prophylaxis of your choice is also important. Adequate bowel preparation and a bladder ultrasound can also assist in ensuring that there are reduced complications. The selection of the catheter size, pre-marking of the exit site, and as I've explained before, the antimicrobial skin preparation and prophylactic IV antibiotics. It's very important to know your patient. And as you'll see on this screen, patients come in all shapes and sizes. I try to have a conversation with the patient that includes whether they're left or right-handed, whether they're a golfer, because you don't want to get in the way of somebody's golf swing. So you want to ensure that the catheter is on the opposite side. That the exit site is marked in relation to whether a patient may ride a motorbike because they might have to wear body armor, or whether they play the guitar, because again, that will determine the side in which the exit site should be. So on this slide, you'll see that it shows the catheter placement and placement of the exit site. And you can see that the exit site should be at least 2 centimeters clear of the distal dacron cuff. Marking the exit site pre-insertion is very important, and this should never be done with the patient lying down. As you can see on this slide, you want to avoid skin folds, and you want to avoid the belt line for the patient, which is what is happening on this slide, and you can see clearly where the patient's exit site is marked. The ISPD guidelines suggest preoperative mapping to select the most appropriate catheter size to achieve the correct placement of 5 centimeters below the upper border of the pubic symphysis. Now, catheters can be swan-necked, straight, or pre-sternal, depending on the patient. So we tend to use swan neck catheters of 62, 63, and 57 centimeters. You can use a straight catheter, and there is some evidence that the efficacy of straight catheters can be is slightly improved. And these come in 46, 40, 47, and 42 centimeters. With the pre-sternal catheter, you actually cut to size, and the exit site should be visible to the patient, not underneath the belt line. Very importantly, not in a skin fold. And again, most importantly, that the distal cuff is more than 2 centimeters from the exit site. Now, what we tend to do is actually to use a physical catheter to map the catheter size with the patient. But you can get mapping guides. With PD Access, the devil is in the detail, and each member of the Access team needs to understand the need and attention for detail to reduce complications. Also, the actual dressing of the exit site is most important. And as you can see here, once we have completed the exit site, we try to ensure that the patient has a loop of slack. And this is where the catheter, as the catheter comes out, emerges from the skin, that a loop of slack is then informed so that the exit site heals and the catheter is allowed to sit as it wishes. And that this is important because it reduces the possibility of the exit site becoming enlarged. And as you can see, we use a me-pour dressing. And the reason that we use this is because the skin can breathe through this. And it means that the catheter is protected, but the healing process and epithelialization is allowed to happen. So an appropriate dressing should not be a dressing that is going to make the catheter damp underneath. So I would say, please do not use Tegaderm. Try and use a dressing such as a me-pour dressing. The catheter should be immobilized, and it's important that during the healing process that you do not disturb the catheter any more than once a week for the first 3 weeks, depending on when you're going to use the catheter. So what we tend to do is we tend to dress the catheter at the time of insertion, and then we do not disturb it for another week. You can use at this point a biopatch or any other antibiotic impregnated dressing in order to assist with healing and prevent infection. You should only take down the dressing on suspicion of infection or trauma, and you must keep it dry at all times. Now, the important thing is that the patient understands this, and we try to explain to them that they shouldn't shower for the first 3 weeks, but instead that they should strip wash so that the exit site never becomes wet, and this prevents infection. Obviously, in preparing for the catheter, laxatives can be very important, and do consider whether your patient already has issues with constipation. And if they do, you can start laxatives early, up to 2 weeks, and maybe something like Senna or Docusate before the catheter is placed. Otherwise, we tend to start these laxatives 5 days before the procedure, so Senna and Docusate BD. We want to ensure the patency of the catheter, and of course, at the time of catheter insertion, it's important to check the patency of the catheter at that point. And so, do flush your catheters. We tend to flush with saline, but you can flush with PD fluid. So, also consider prophylactic topical ointment, but this should only be done once the patient's exit site has healed. And as I said, that can take up to 3 weeks. Consider face masks in patients who have persistent cough. So it's important to understand if a patient has persistent cough before having the catheter inserted. And it's all about education, education, education. We tend to swab the patients to ensure that they do not have MRSA. And we also tend to give the patients mupirocin ointment 3 times a day, intranasal, for 5 days before catheter placement to ensure that no staph A infection is possible for the patient to give to themselves. You do need to get personal with the patient. You need to talk to the patient about what they do on a day-to-day basis, and use this time to make sure that the patient understands that they are a priority in the catheter healing process. So a dedicated PD nurse should provide planned post-implant education at least weekly to ensure correct catheter exit site healing. And this is the most important process because a well-healed catheter, patent catheter, will provide your patient with years of good patent PD access. So this shows a picture of what the detail that we go into is. And you can see in this picture that we provide pictorial pictures of exactly what we need when we're doing an exit site dressing, how to prepare the area for exit site dressing. So do have a look at the clinical practice guidelines for peritoneal dialysis of 2010 and also 2019. Flushing the PD catheter and capping off using a suitable dialysate. Remember that you need to do that once a week for 3 weeks. Use a suitable non-occlusive dressing, such as a me-pour dressing, and try not to disturb for 5 to 10 days. At King's, we don't disturb for 7 days. And as you can see, immobilizing the catheter so that the exit site can heal well is extremely important. Use me-fix as an anchor dressing. You want to ensure that the catheter itself, if it gets pulled unintentionally, is not going to result in trauma of the exit site itself. And discharge the patient with a supply of aperients and advise on recognizing potential complications. A post-op advice sheet is really important, and that will allow the patient to understand their responsibility and what they should do in regards to the healing of the catheter. So what we do is we provide them with a do and do not sheet that shows them clearly what they should consider in the weeks after the catheter has been placed. And so keeping your appointments is really important, and taking your laxatives obviously is very important for the patency of the catheter, and ensuring that the patient is discharged, and I can't say this enough, with laxatives enough for 3 weeks. And actually taking painkillers is very important. Often patients have things such as cocodamol at home and other analgesics that can cause constipation. So it's important to ensure that they understand that they should only take the analgesics that they are discharged with, such as plain paracetamol. We also provide them with a do not sheet, such as having a bath or having a shower until the PD exit site is healed, taking down their dressings. So what we do is we provide them with dressings that are large enough to cover the entire exit site, and to, if it starts to become undone, that they can place a dressing over the exit site to protect it. And we also make them aware that it is important that no one other than PD trained staff should take off their dressing, because sometimes you might find a patient has been admitted for an ultrasound in another department, and that can cause many problems if the dressing is taken down, etc. They also shouldn't do any heavy lifting of groceries for up to about 6 weeks, and they also shouldn't drive for a week, because that can change the peritoneal pressure if they had to do an emergency break. So exit site infection is a possible complication post-operatively, and you need to use your clinical judgment in regards to whether this should be treated or not. Pericatheter erythema is often just an indication of catheter implantation or trauma. So swab and wait if you are in doubt, and treat as per the sensitivities, and then re-swab once the catheter exit site appears healed. Patient training should be comprehensive, and it should be ongoing. So once you have trained your patient, and I get asked the question often, how long is it going to take to do my training? The answer is it's going to take a different amount of time for every patient. And what's important is that the location of the training, and often the patient's home is the best location, but if that is not possible, that it is one-to-one training with a nurse who has considered how the patient learns. And that can be the patient can learn in many different ways. Some people prefer written education materials. Some people prefer pictorial education materials. And some people learn by touch. And so therefore they have to do the procedure over and over again in order to learn it. So it's important important that we manage any post-operative complications. So peritonitis and exit site complications within 2 weeks of the catheter are considered a post-op complication. And that can be actually up to 4 weeks post catheter insertion. Dialysate fluid leak, catheter dysfunction at the first time of using the catheter, and you may need to manipulate or reposition the catheter in order that it works correctly. You should monitor all PD related infections, both exit site infection and peritonitis. You should also identify any presumed cause and cultured organisms, and you need to foster this continuous quality improvement. Knowing your organisms within your own PD service is very important, because that will allow you to improve PD exit site and peritonitis rates moving forward. And taking samples should be done really with a PD effluent sample plus 2 other PD effluent samples in blood culture bottles. So you need up to 20 mils in each. So we have a nurse-led PD catheter service at King's College Hospital, and that allows us to respond immediately to complications in PD access. But the important part to remember is that as long as you have a PD access program which is responsive, so that may mean GA catheter insertion 3 times a week, or it may mean that you put PD catheters in under ultrasound guidance as we're moving towards. But the point is that it should be responsive to the patient. The patient should not have to wait lengthy times to be seen and or to have their complications treated. Here are some references which you may find helpful, and I hope that you have enjoyed this session. And please let me know if you have any questions. Thank you for listening.